before that, I thought that I'd left out this topic and it was kind of, I don't know, important. So I'm gonna just touch on this once. Okay, so there are two types of like lung opacities: diffuse lung opacities, interstitial and alveolar. Okay, so in alveolar, the difference between interstitial and alveolar lung opacities is that interstitial opacities are like more defined, like reticular, nodular. You can give them shapes. Okay, but alveolar lung opacities are more like ill-defined opacities, and they are mostly seen in like pulmonary edema. So it can be two different types: cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. Okay, so there are some features that you see in a chest X-ray of pulmonary edema which can help you to differentiate if it's cardiogenic or non-cardiogenic. So the first one is air bronchograms. So air bronchograms, we already know what that is. Yeah. Okay, so air bronchograms is basically um, uh, like the bronchi is visible in a chest in the chest X-ray when the alveoli surrounding the bronchi becomes opacified. So opacification of alveoli adjacent to bronchi result in dark air-filled bronchi becoming identifiable, like you can see over here. Okay. Over here, it's not very clear, but I think we've seen X-rays in previous class in which it was more clear. This bronchus is visible over here. Can you guys see? Are you guys able to see? Okay, that's an air bronchogram. So the bronchi becomes more translucent because the alveoli surrounding the bronchi has become opacified. Okay, I'll continue. Are you guys able to see though? So can someone say yes, no? Yeah, okay. Okay. So the basically what I'm saying right now are the features are like 2 3 features which can help us to differentiate between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. The first feature is air bronchograms. So what is air bronchograms? Air bronchograms is basically because I think I'll draw it over here. Okay. So suppose this is like the bronchi is going over here. Okay, and around the bronchi there are alveoli. Okay, so usually the bronchi is also translucent, the alveoli is also translucent, so the bronchi is not very visible. Okay, but if due to pulmonary edema, these alveoli they have fluid in them and they become opacified around this bronchi. So then this bronchi becomes translucent and more visible. So this is what you can see over here. Okay, there's a bronchi that's visible because the surrounding alveoli has become opaque. All right. Okay, so I'll go to the next one. The next feature is peribronchial cuffing. Peribronchial cuffing is because of interstitial edema that is around the bronchi, in the bronchial wall, which makes it look thick. Okay, so that is called peribronchial cuffing. Okay, so in this X-ray over here, I mean, this is not the full X-ray, okay? This is like zoomed in, okay? Not of this, some other X-ray zoomed in, okay? I just want to show peribronchial cuffing. That's over here, okay? Can you guys see it? You can see two circles like this. I'm not sure how much is it visible. Yeah, this X-ray is not the full X-ray. It's like zoomed in mid-lung zone. Yeah, okay? So are you guys able to see like these two peribronchial cuffing kind of feature? Yes, no? Yeah, visible. Okay. Okay, so those are the first two things: air bronchograms and peribronchial cuffing, right? Okay, so the next is curly lines. Okay, curly A lines and curly B lines. So curly A lines are basically curly A lines are like diagonal lines. They extend from the hilum towards the edge. Okay, and they're unbranching. Okay, and curly B lines are faint, thin horizontal lines, and they are seen at the periphery. Okay, usually at the base. Okay, so can you guys see over here? Wait, let me just zoom this in. Can you see these lines over here? Okay, those are curly B lines. Okay, curly B lines are actually more important and they're more visible. Okay, curly A lines are like I think this one, but this also looks like the fissure to me. I'm not sure where curly A lines are. I think over here. Okay, so those are curly A lines, and this is curly B lines. Okay, okay. So curly A lines are like horizontal lines towards the periphery, and they'll be curly A. Hello, hello. Can you hear? Yeah, yeah. Okay, okay. So yeah. So curly A lines, they are connection between like curly A lines. They're a horizontal line extending from the hilum towards the periphery, and they're usually unbranching, and they represent the connection between the central and peripheral lymphatics. All right, and curly B lines, they are mostly at the periphery and towards the lung bases, and these are like these small horizontal lines. Okay, and they represent the interlobular septa. Okay. Class children will be. Okay. So they represent the interlobular septa. Okay. So the next so those are curly lines. The next is cephalization. So normally, um, okay. I'll if I pause, I'll ask you guys to type something. Okay, fine. Okay, so so the next thing is cephalization. Okay, cephalization is basically usually the pulmonary vessels are more visible towards the lung bases. Okay, so the pulmonary vessels they're more visible towards the lung bases. So the lung bases appear more radio opaque compared to the uh, up like the upper fields. Okay, so but in pulmonary edema, um, there will be increased visibility of pulmonary vessels in the lung apices. All right. Yeah, so this cardiomegaly, I mean, this is like a mitral valve replace post mitral valve replacement surgery. So you can see there are sternotomy rings over here, and there's some artificial valve also here. Okay, so so basically, in cases of pulmonary edema, we know no, when like there's left heart failure and there's um, basically like yeah pulmonary edema. So the pulmonary vessels in the apices become more prominent than the bases. Usually it's the other way around. The bases are more prominent than the apex. So that is called cephalization. So if the pulmonary vessels of the apex are more prominent, it's called cephalization. All right? Did you guys understand that? Yes, no? Okay. Okay, so the next thing is called bat swing pattern. A bat swing pattern is when because of the edema there is opacification of the bilateral hilar regions. Okay, so it gives the bat swing bat swing pattern. Okay, yes. Okay, so that is bat swing pattern. All right. Yeah. Okay. So now with these features, that is what was the first one? Bronchogram. Yeah, air bronchogram, peribronchial cuffing, curly B lines, cephalization, and bat swing pattern. We can differentiate between cardiogenic and non-cardiogenic pulmonary edema. So cardiogenic pulmonary edema, very obviously, the first thing will be that the cardiac size will be enlarged. There will be cardiomegaly. Okay, and it will be mostly homogeneous. Okay, whereas non-cardiogenic ARDS will have patchy opacification. Okay, air bronchograms will be more common in non-cardiogenic pulmonary edema because the alveoli will be involved in that case. Okay, then peribronchial cuffing is more common in cardiogenic, and because of and then in cardiogenic there'll be concurrent pleural effusion and curly B lines are more common. All right. So basically, in cardiogenic, you have cardiomegaly, you have peribronchial cuffing, you have curly B lines, and pleural effusion. That's how you can remember it. And non-cardiogenic is more patchy, and it has air bronchograms. Okay. Okay, so so that is what I want to teach. Now we'll just do X-rays and cases. So there'll be a case, then there'll be an X-ray, and then we'll try to find out what it is. Okay, so this is the first one. Okay, a 65-year-old smoker comes with 4 weeks of hemoptysis and progressive dyspnea. The exam, he was mildly cachectic and in moderate respiratory distress. Vitals, heart, there was tachycardia, BP was high, and low oxygen. Then okay, and then on chest examination, there was complete absence of breath sounds on the right side. Okay, so now this is the X-ray. So what do you guys think it is? Collapse, yes. Okay, so it is collapse. It is, yes, right-sided atelectasis. Okay, so here you can see the trachea. The trachea is deviated towards the right side. Okay, chest X-ray PA view with deviation of trachea to the right side and a homogeneous opacity in the entire right lung field. Okay, not even trachea, even the mediastinum, the heart is kind of deviated to the right side. Okay, so this is which is showing total lung atelectasis of the right lung. Okay, okay. Yeah, and so that's consistent with the examination. Also, we had complete absence of breath sounds on the right side. Okay, so okay, everyone got that. Okay, next case. 23-year-old woman who returned recently from a trip to Africa presents with 4 weeks of cough, intermittent fever, and weight loss. She appears chronically ill, but in no concurrent distress. Vitals is unremarkable aside from a BMI of 19. On chest, there's dullness to percussion and crackles in the right lung base. Okay. This one has two X-rays, PA view and lateral view. Okay, so we'll do them both one by one. What do you guys see in PA view? Somehow people take a lot of time to type during classes. Yes. Okay. Right. So we know it's in the right lower. Yes. Okay. So the thing is, we know it's in the right lower lung field, and here you can also see like the silhouette sign. It's kind of making the diaphragmatic silhouette that we learned in previous classes unclear. So it's more likely in the right lower lung field. Okay. And that we can also confirm uh, uh, in the lateral view. Okay, there's a right lower lobe opacity. Okay, so but there's also one more thing over here. The hilum on this side is kind of has an increased opacity. So like it's not very obvious, but it could be. It's subtle. So that can indicate right paratracheal lymph nodes as well. Okay. So yeah, so yes, right lower lobe, perihilar. Yes, sorry, perihilar nerve. Okay, so or paratracheal. I think it's the same. I don't know. Anyways, okay, so it could be right lower lobe pneumonia. Okay, but like as per history, she had 4 weeks of cough. Okay, and okay, so it could also be TB. So it could be either of them. Okay, all right. Yeah. Okay. So the next case. One sec, I'll just put them all in one screen. Okay, so 38-year-old man came with history of IV drug abuse. Uh, with a history of IV drug abuse, presented to the ER with fever and a new heart murmur suspected to be due to endocarditis. And then he subsequently developed progressive hypertension and respiratory distress over the first 12 hours after admission. Okay, so general examination is intubated and appears critically ill. He has a fever, tachycardia, hypertension, everything. Okay, then chest has diffuse loud crackles bilaterally. Then there is systolic murmur in the right upper sternal border and the left upper sternal border. Okay, so now this is the X-ray. Okay, so he's kind of an ICU. He has all these wires connected to him. Okay. So what all things can you say about this X-ray? What about the quality of this X-ray? So is the rotation right? The exposure right? Yes, he will have. No, that is like because he's intubated, right? After, like the ET tube is usually connected to the ventilator through this kind of a pipe. So that's the pipe that's coming in the X-ray. Yes, the lungs look small because it's probably because he is not maximally inspired. Okay, so not all the usual number of ribs are not visible. Okay, so it's not of maximally inspired. Okay, yes. Okay, yeah. The diagnosis is ARDS. Okay, um, left side lucency. That's fine actually. It's not like the left side is actually normal. It's basically everything else is that's pathological. Okay, so basically, so first of all, this film is rotated. Like the patient is not straight. It's kind of rotated multi-axially. Okay, then you can see the vertebrae is not visible behind the cardiac silhouette. Okay, so it's not properly exposed as well. Okay, but anyways, we can see all these patchy opacities. Okay, all over the bilateral lung. Okay, and we see that the heart is not enlarged. Okay, we can see air bronchograms are there, right? Okay, so this is non-cardiogenic pulmonary edema, which is most commonly due to ARDS. Okay, so this is ARDS. Okay, one other thing, can you see something else in the trachea over here? I mean, there are a lot of wires, but what is there in the trachea? Hello, why is no one typing? Zoom in? Okay, I'll zoom in. Yes, yes, ET tube. Okay, so ET tube. So when we place the ET tube, okay, usually we do an X. Yeah, yes, correct. Okay, yeah, true. Oh, okay, okay. So this is the ET tube over here. Okay, can you guys see that? So basically, on X-ray you can check if the ET tube is correctly placed. Okay, so how do we check that? This is the edge of the ET tube. Can you see it over here? Till here is the edge. Okay, so from the I got nothing. Okay, okay. So can you see these two white lines over here? This thing does not work. Yeah, yeah. Okay. So these two white lines. Okay. So those are the edges of the ET tube. Okay, so those okay. So this is the edge of the ET tube, as in like this is the end. Okay, and and the carina is somewhere over here. The bifurcation of the trachea. Okay, so it should at least be 3 centimeters from the bifurcation of the trachea. Okay, that is the correct positioning of the ET tube. Okay, so using a chest X-ray, you can check that. Okay, the ET tube should be at least 3 centimeters from the bifurcation of the trachea carina. Yes. Okay. Okay. Okay, so that's all in this X-ray. Yeah, we did all that. Okay, there's some effusion. Okay, okay. So the next one sent it to the ER to go with dyspnea and uh, large chest tube. Okay, okay, okay. Hello, hello. Can people hear me now? Hello. What is happening?
हेलो हेलो
Yeah,
दीदी आपकी आवाज कट गई थी बीच में आप ठीक है
अभी आ रही है. You
हाँ
guys
जी
can hear. Okay, okay,
या नाउ इट्स गुड
okay, okay. Okay, thank you. Okay, so now we go to the next case. Okay. 68-year-old man presented to the ER 2 days ago with dyspnea and 15 kg weight loss. And he was found to have large lateral pleural effusion, which is drained via chest tube. Okay. He initially felt improved, but then abruptly developed severe shortness of breath and hypotension. Okay. So in general examination, he's in severe respiratory distress. Okay. He has tachycardia, hypertension, tachypnea, and low oxygen saturation. Okay. And chest examination, there is absent breath sounds and hyperresonance throughout the left hemothorax. Can someone guess what it is without the chest X-ray? Yes, pneumothorax. Very good. Okay. So yes. Okay. Yes. Okay. So okay. Yes. Okay. So this is the pneumothorax left-sided. Basically, what happened is, um, so he had a chest tube, and the chest tube kind of moved towards the extrathoracic region. Okay, you can also see there's deviation of trachea. It's supposed to be deviation of trachea, which I cannot. I think this is the trachea over here. It's kind of deviated. Okay, everything is deviated. Okay, so there's like a tension pneumothorax, and yeah. Okay, and so this. Can you see this coiled up thing over here? This thing. This is the chest tube. Okay, it's supposed to be well inside. I think this is the mouth. Okay, or something. Okay, so it has no. That is it? Yeah. Okay, so it has kind of moved towards an extrathoracic region. Left-sided dot dot meaning? Yeah. So there is some pathology on the right side as well, but we don't know. It could be anything. It could be some, like COPD kind of stuff happening over there. Okay, so that is also pathological, but we don't know what it is. We cannot know for sure. The diaphragm is over here, I think. Yeah, interstitial opacity. Yeah, reticular pattern. Okay. So basically, because of the chest tube has moved to a more extrathoracic region, the patient has developed tension pneumothorax. Okay. Mhm. Okay. So now we go to the next case, case 5. 76-year-old woman presents with 1 week of progressive dyspnea and bilateral swelling. Bilateral, I think, pedal edema. Okay. She reports surgery 30 years ago due to some problem with the valve and has been on Coumadin since. Okay. Um, and general examination, the lady has mild respiratory distress. There's tachycardia, high BP. Then there's mild bilateral crackles, irregular rhythm, and a systolic murmur and elevated GAVP. Okay. So now this is the X-ray. Okay. What do you guys see in the X-ray? Can you see it now? Is it stuck? Oh man, why is it Why is this happening? Wait a second. Okay, I will just okay. Okay, so tell me now, what is it? It's complicated. Yeah, this cardiomegaly. Okay. Yeah, you said it first, but I saw that. Okay, there is sternot. These are sternotomy rings. Okay, so they indicate that previously she had some cardiothoracic operation. Okay, and this one, this thing that you see, this is a prosthetic valve. Okay, so okay, that is a prosthetic valve. Okay, this one over here. Okay, that's a prosthetic valve. Yes. Okay. So how do you know if it's tricuspid or mitral or what? Okay. So how do you find that out? Okay. So okay. Okay. So that is not the actual diagnosis. Okay. Yeah. Okay. So no. Okay. So basically, what we do is, this is the spine. Okay, and we draw a line bisecting the spine, something like that. Okay. I'll show you this picture better. Okay. So okay, so the tricuspid is usually located somewhere more inferiorly towards this side. Okay, and the ones on this side is mitral. The aortic is better visible on a lateral chest X-ray. On the PA chest X-ray, it looks more like side view kind of thing. Okay, and pulmonary is over here. All right. Did you guys get this? Can you guys hear me? Yeah. So basically, like, how do we know which valve it is, right? Yeah. Okay. So basically, what we do is we take the shadow of the spine and the cardiac right over here. Okay, and we draw a line bisecting it. Okay, the tricuspid will probably be somewhere over here. This will be mitral. Aortic will be like end on over here, and pulmonary will be over here. Central point is like, I think it kind of, like, I'm not sure about that, but I think it kind of bisects this line, like midpoint of this line. I think somewhere at the center of like the heart. So I'll tell you. Okay, basically, yeah, but basically you need to get a rough idea. So mitral is somewhere on this side, aortic is more end on, tricuspid will be somewhere more over here, and pulmonary over here. Okay, so but that is not what we're looking for in this X-ray. This X-ray has cardiomegaly. What else does it have? Yeah, this is a prosthetic valve. This is not the normal mitral valve. It is prosthetic. Okay, and actually, like this shape, this has a, like, you can tell the name of the valve, the prosthetic valve that is inserted by its shape. But I thought that was just too much detail, so I yes, there is effusion. You're right. There's effusion over here. Okay. Uh, and also there is what we call cephalization. The pulmonary vessels on the apices are more visible. Okay. Where's coffee now? Yes, I think this. Oh, wait. Yeah, it is a woman, right? 76-year-old woman. Coffee has been obsessing about since last night. Yeah. Okay. Okay. So yeah. Okay, we're done with these X-rays. Okay, this is possible CHF exacerbation. Yeah. Okay. Yes. Now next. Okay, next. Okay, next 45-year-old man with alcohol dependence presented with 2 weeks of productive cough and high fever. Okay, I'm at home, so that's why I want to say it. Okay, 45-year-old man with alcohol dependence presenting with 2 weeks of productive cough and high fever. Examination, general appears acutely unwell, and then has fever. Why is this coming like this? Yeah, tachycardia. Hmm. Okay. 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 Yeah. So no, they didn't say okay, okay. Let's just not talk about that. Right? Yeah. 45-year-old man with alcohol dependence presented with 2 weeks of productive cough and high fever, and basically he has fever. Everything else looks pretty normal. Okay. And so this is a chest X-ray. Okay. And what do you guys see here? Yes, cavity. Yeah, abscess. So there's a cavity in the. There's a cavity which looks like. Where do you think the cavity is? Yeah, it looks like in respects of the lung, it looks like it's in the right mid lobe. Okay, yeah, middle right lobe. That's what it looks like in this X-ray. Yeah, and there's air fluid levels. Okay, but now we have a lateral X-ray as well. Why is my pen coming? Okay, so this is the lateral X-ray. Can you see the abscess in this X-ray? No. Let me zoom. Now can you see? Yeah? Yes. Where do you see it? Bats behind. Yes. Okay, so this is the abscess over here. Okay, so this is actually in the right lower lobe, not in the right middle lobe. Okay. So sometimes lateral X-ray helps you. Okay. Yeah. Okay, with air fluid levels in the right lower lobe. Okay. So it can be a lung abscess because of pneumonia. It could also be due to TB. Yeah, because of the illusion. Yes. Okay. So now the next case, we'll go to the next case. 55-year-old non-smoker with no significant previous medical history presented with 2 months of progressive dyspnea. Okay. Um, Everything else is pretty okay. There's diffuse bilateral fine crackles on chest examination. Okay. Mm, okay. So this is the X-ray. So what do you guys think it is? He had 2 months of dyspnea, progressive dyspnea, and there's diffuse fine bilateral crackles. So what do you guys think? Not effusion. It's a more chronic thing. Yeah, there are reticular bilateral reticular opacities, diffuse reticular opacities. Yes, yes, yes. Yeah, Bats is right. This is more probably idiopathic pulmonary fibrosis. Okay, and there's some widening of mediastinum also. Okay, when the he has to okay, it doesn't have to be without like it can be without smoking also. It's idiopathic pulmonary fibrosis. So he has low oxygen saturation also a little bit. Yeah, yeah, yeah. Okay, yeah. So and like basically there is some widening of mediastinum. You say widening of mediastinum if this is more than 8 centimeters, the width of the mediastinum at the aortic knuckle. Okay, so it's not very obvious, but it could be. It could either be due to a tortuous aorta or it could be due to an aortic aneurysm. Okay, so those two things are there in this X-ray. All right, I'll go to the next one now. Okay. 45-year-old man with HIV presents with intermittent fevers and weight for over 6 weeks. Okay. The patient appears cachectic and there's fever, little bit of low. It's okay only, I guess. Yeah. Okay. Then mild crackles bilaterally and regular rhythm. Okay. Yeah, I guess it is TB. Okay, so what is this X-ray? I heard something. I think this is lagging. 1 second, okay, I'll just check my Wi-Fi, okay. Hello? Can you hear me now? Can you see the screen now? Okay, so what is it? What is the X-ray showing? Yeah, miliary TB. Okay, so this is miliary TB. Because there's diffuse micronodular opacities bilaterally. Okay, yeah. Okay, so this is pretty simple. Okay, and it's more on the more prominent on the right than the left. Okay, yeah. Okay, and it could also be any fungal infection as well. Okay, if depending on the exposure. Okay. Okay, so now this next one. Yeah. Okay. So 35-year-old woman, okay, with scleroderma, presented with subacute progressive dyspnea on exertion. Uh, appears well, febrile. Okay, the only important thing over here is increased JVP. Okay, yeah, millet seed appearance. Okay, that's why it's called miliary TB. Yeah. Okay, so this is the X-ray. What do you guys see in this X-ray? Yes, thick pulmonary vessels bilaterally. It's not. It's more of like the pulmonary vessels on both sides. Okay. Okay. So this is pulmonary hypertension. Okay. She has pulmonary hypertension. Yeah. Okay. So that is bilaterally enlarged hyla, probably pulmonary hypertension. Yeah. Okay. So this is the next one. 52-year-old woman with 20 lb pounds of weight loss over 6 months and intermittent fevers. Case exam is unremarkable. Somehow I don't remember what this case was. Oh, yeah, I think I know. Yes, yes, I know now. Okay, yeah. Okay. Weight loss and intermittent fevers, okay, for 6 months. Okay, so what is this X-ray now? Can you show this again? Which one? This one? Yeah. Can you basically there is the hilum over here. There is some widening of mediastinum. Okay, so as you guys said, it could also be aorta, but aorta is more superficial over here. This is the aortic knuckle, okay, which is okay, which is not that big. It's fine over here. Okay, it's more enlarged over here. Okay, so this is the what is yeah, so this is basically the left pulmonary artery and this is the right pulmonary artery. They're more like the opacification is increased over there. Okay, so that is because of pulmonary hypertension, could be because of pulmonary hypertension. All right. Thanks. Okay, so now we'll go to this one. So what do you guys think it is? I mean, are you able to see something or not? There's a lateral X-ray also. If you're not able to see over here, I'll show you the lateral X-ray. Hmm. Yeah, they are kind of flat. Yeah, okay, so there is some hilar mass. Okay, you got it. Okay, yeah, so there's some mediastinal widening. Okay, it's not very, like, it is appreciable, not very appreciable over here. Yeah, okay. So I'll show you the lateral. Okay, yeah, but what is it? Okay, now you have the history for that. It is a mass. Okay, okay, okay. So over here, yes, okay. So over here in the lateral chest X-ray. Okay, let's. Okay, so in the lateral chest X-ray, what do you guys see in the lateral chest X-ray first? Tell me. Okay, what do you guys see the lateral chest X-ray first of all? Yes, anterior mediastinum is filled. Okay, so there's supposed to be a retrosternal space over here, which is not there. It's filled because of the mass. Okay, so in anterior mediastinum there are many things. There's thymus, there's thyroid, there's okay, but there are also lymph nodes. Okay, yeah, but she's a 52-year-old woman. She won't have thymus, so okay. Um, and she has six weight loss for 6 months and intermittent fevers. So this is yeah, but it can also come as an anterior mediastinal mass. It also comes under anterior mediastinal mass if a thyroid mass is there. Yeah. Okay, so she has a lymphoma. Okay, mediastinal lymphoma. It could be a lymphoma. Like we're not sure. Okay, we could be. Okay. Okay, so we'll go to the next case. Okay, let's go to the next case. We're not even done with half the class till now. Yeah, okay. You said I missed it. Where did you see it? Anyways, I think I missed it. I'm sorry. I'm sorry, Soups. Okay, next. Okay, next. Okay. Case 12, we go to 58-year-old woman with liver transplant recipient. 58-year-old with liver transplant recipient, why am I saying woman? Presents with fever, chest pain, hemoptysis, and dyspnea, progressively worsening over a course of a week. Okay. This patient appears acutely ill, with fever, okay, low oxygen saturation, okay, and bilateral course crackles throughout. All right. So, what do you think it is? What do you guys think it is? Hello? Can you guys hear me? Yes, pneumonia. Yes. Okay. So this is the chest X-ray. Okay. So what is the finding in this X-ray? Yes. So there is bilateral diffuse nodular opacities. Okay. So these are multiple pulmonary nodules, basically. These. Okay. These. Okay. So in the classes we discussed that multiple pulmonary nodules can be a lot of things. It can even be malignancy. But in this case of a transplant recipient having infection-like symptoms, it can be due to pneumonia, like fungal pneumonia. Okay. Okay. Probably fungal pneumonia. Yes. All right. Okay. So now we'll go to the next case. Okay. Yeah. Okay. So this is because this is final chest X-ray class. Anyways. Okay. Next case, guys. We're running low on time. 56-year-old man with no previous medical history came to urgent care clinic with 2 days of sore throat and fever. Okay. He appears moderately ill. He has fever, tachycardia. Everything else is okay. Artemis, pharynx, and exudates. Several enlarged and tender cervical lymph nodes. So basically, we're doing an X-ray to see if he has pneumonia or not. Okay. Okay. So now we'll see the X-ray. So what do you guys can say about this X-ray? Very good, Bhalu. Okay. What is what? Age is 56-year-old man. Someone's mic is on. Features. Yeah. I think those are some leads or something. Not important. Yeah. Okay, so basically, what we see in this X-ray, this X-ray is actually pretty normal. Okay, there's no pneumonia. Your corpse is okay, and then basically he has this is not a maximally inspired X-ray because only 1, 2, 3, 4, 5, 6, 7. I think 7 or 8 ribs are visible. Okay. Okay, so 8 posterior ribs are visible. More, at least 9 to 10 posterior ribs should be visible. Okay, so yeah. Okay, so this X-ray has low lung volumes. That's the first thing. There's no pneumonia. It's normal. And the second thing is, as you guys pointed out, liver is not visible. Okay, okay, but what you can see is some like translucency over here with these kind of lines things. Can you see these lines? Can you see those lines? Yeah. Okay, so those are basically hostra. Okay, so that is a loop of intestine has come um, uh, between the inferior surface of the diaphragm and the superior surface of the liver. Okay, there's a loop of intestine below below the inferior surface of the diaphragm and above the superior surface of the liver. Okay, so this is the diaphragm, and there is a loop of intestine and then liver. Okay, so that is what we're able to see. Okay. Yeah, this is it's not a hernia. It's not a hernia. It is just that the loop is placed over there. Okay, this is it's kind of an incidental finding. We were not looking for it. See, the left side, this can just be the gastric shadow. It does not have to be loops. With this over here, you're supposed to see an opacity of the liver, right? Yeah. Okay, so this is called Chilaiditi sign. Okay, Chilaiditi sign. Okay. Chilaiditi sign is the interposition of bowel, usually colon, between the inferior surface. Chilaiditi, the spelling is over here. Chilaiditi. Okay, Chilaiditi sign. Okay, yeah. I mean, in this X-ray, usually it's asymptomatic and we don't have to do anything about it. In some cases, this condition, Chilaiditi sign, causes abdominal pain, abdominal cramping like pain. Okay, if there is pain associated with, then it is called Chilaiditi syndrome. Okay. All right. Plain measles. Okay, so see, basically, this is no big deal. Okay, basically, it's no big deal. There is a loop of colon located below the diaphragm and above the liver. Okay, so instead of seeing the normal liver opacity, you're seeing these translucency and hostra. Now, suppose like some people might think this is some perforation of some kind, there's free air under the diaphragm, but this is not free air under the diaphragm because of the presence of hostra, you can know that this is actually a loop, bowel loop. It's not free air. Okay, if these sometimes if you're still confused, you might do a CT chest, okay, to confirm if it's actually perforation or if it's just Chilaiditi sign. Okay, so yeah. Okay, so Soups, you got it. So it's usually like it's asymptomatic, nothing really happens. You just discover it incidentally. In some patients, it causes abdominal pain. If it causes abdominal pain, it's called yeah, it's not really, see, usually loops are not really held in place as such, right? They are mobile. I mean, some of them are held in place, but not all of them are held in place. It's just a variation kind of a thing. In some people, it's like this. No, I said there's a lateral of the previous one. This one. Yeah. Okay. Now this one. Yeah. Okay. Now this one. This one's interesting. Okay. Whoever figures this one out, I'll give them a cookie. Okay. Okay, so 80-year-old man with multiple cardiovascular risk factors presents to the ER with progressive constant chest pain for 2 weeks. Okay, he appears thin. He has hypertension and everything else is okay. Okay, everything else is okay. Okay, so Soups thinks it's an MI. Okay, so in MI we do ECG, but we also do chest X-ray sometimes to rule out if there's other must not miss conditions like pneumothorax and stuff. Okay, so we also do a chest X-ray over here. Okay, so this is the chest X-ray that we see. So it doesn't look like pneumothorax and stuff, right? But is there something else that 2 weeks of pain? Yeah. So is there something else that you guys can see over here? Yeah, but he's an 80-year-old man. An 80-year-old man, his can become a bit small. It's called microcardia. It's there in the Next be X-ray. COPD, trauma. No, 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 no. No, no, no. See, look at the symmetry of this X-ray. Somewhere it's asymmetrical. It's not symmetrical. It's not pneumothorax. I said it's not pneumothorax. I already told you so. Somewhere this X-ray is asymmetrical. Like just look at both sides and spot the difference. Yes, ribs, 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 ribs. Yes, yes, yes. Which side? Who is this? Where did you say ribs, Bhalu? I never saw you say ribs. It's not on the right side. Yamadu, what do you think? He has 2 weeks of chest pain, guys. 2 weeks of chest pain. It's not MI. You can't have MI for 2 weeks. It's not fracture. It's not on the right side also. Now come on. If it's not on the right side, it's on the other side, obviously. So don't look at. See, it's not a. See, he won't even have like a fracture for 2 weeks and be okay with it, right? Okay, now everybody look at the left side of the X-ray. Okay, do not look at the right side anymore. Yes, yes, Soup is right. Okay, yeah, yeah. Also Venice. It's not a dislocation as such. Okay, so um, this is basically sclerosis. Okay, increased opacity, sclerosis of the rib. Okay, calcification, sclerosis. Okay, so it could be due to a lot of things. Okay, it can be due to but you were the first one who pointed out ribs, so I that's yeah. Okay, so this could be due to a metastasis causing sclerotic, lesion in the bone. Okay, which is causing him pain. Okay, so so it could be a metastasis, sclerosis of the anterolateral aspect of the left fifth rib, suspicious of metastatic disease. Okay, so now I don't know who gets the cookie. Okay, 8-year-old man with multiple. So this is like a case that's just trying. Basically, what we're doing in this patient is we are working up for MI. We're trying to rule out MI. Okay. Right. Okay. So he has multiple cardiovascular factors, comes to the ER with progressive chest pain for 2 weeks. See, even if he does not, even if it's 2 weeks, everyone will still, do the MI workup in this person. Okay. So you just do a chest X-ray to rule out other things like pneumothorax and stuff. Okay. And this is something which yeah, so we're not asking. He came to the ER, so we're just right now we're just working him like he has an MI. Okay, so we just did an X-ray incidentally. So if a person who just looks at this X-ray for pneumothorax will say that this is normal and leave it, so he might miss something which he could have caught and help this person. So that's the point of this X-ray. Yeah. Okay. Okay. So this one. Okay, a 63-year-old woman comes with no significant previous medical history to the primary care clinic with hemoptysis for 4 weeks. Okay, then yeah, okay, everything else is okay. Just hemoptysis for 4 weeks. Okay, and this is the X-ray. Oh, sorry. What do you guys see? This is also actually very hard. I mean, I would never figure it out if I see it first time. Okay, so I mean, if he's having chest X-ray continuously for 2 weeks, I don't know if you would. Doesn't have anything in the history except for hemoptysis for 4 weeks. A 63-year-old woman. Everything else is cool. Okay, I'll go to the X-ray now. Okay. Trachea is not trachea. Okay, which side do you guys think is like pathological? Left, left. Very good. Left, upper or lower? Left lower side. Okay. So yeah. So what do you guys think it is? Now, can someone guess? If you guys are that close, then you must know the answer also. What could it be? Not pericardial effusion. Not just this stuff. So basically, I'll show you from the beginning. Okay, so this is the trachea. Trachea is in midline. There's a carina here. So usually this left thing, right? It's supposed to be more horizontal, but it's not. It's kind of extended very down as the right one. Okay, so there's something pulling that thing down. Okay, and over here, okay, there's some actually there's an opacity over here. Which I couldn't see. There's something over here, like the descending. There's some opacity on this side. Okay, so and there's more this part of the lung is more hyperlucent. Did anybody say that? Yeah, yeah, okay. So this part of the lung is more hyperlucent. Okay, so it's kind of actually before that, yes, this is like this like remember in the first class we learned this view called Lordotic View, um in which the clavicles are projected above the lung so that the apices are visualized better. Knuckle is not there, clean meaning for aortic knuckle. So this is actually atelectasis of the left lower lung. This is a very hard X-ray. It's not that obvious. It's more like like the hilum is just placed downwards, and there's some lung collapse. Yeah, atelectasis is lung collapse. Okay. Okay. So now these are the X-rays that are asked in our final year exams. Okay. So now these don't have any clinical cases with them. We'll just look at them and we just do spot diagnosis. Okay. Quickly. Okay. These are the last few things. Okay. Okay, guys. What is this one? Yes, there's cardiomegaly. What else? Not pericardial effusion. When pericardial effusion comes, so you have to answer pericardial effusion that time. Okay. If you miss it, then okay. Okay. So basically, actually, I have to okay. I'll teach you this extra actually. So there is actually straightening of the left border of the heart. Does anybody know what that indicates? Straightening of the left border of the heart. I'm just typing something. Yes, it indicates that left atria is big. So what causes left atrial enlargement? Mitral stenosis. Very good. Okay. So this is yes. Okay. So this is a chest X-ray which shows mitral stenosis. Now in mitral stenosis, there is a lot of things that can happen. Okay. A lot of radiological features. So first is that there is straightening of the left border of the heart. Okay. That is because of left atrial enlargement. It is also called mitralization of the heart. Okay. So the left border is laterally straight. Okay. Also, there's upturned apex. Okay, which not very visible in this X-ray. There's another X-ray in which it's visible. Okay, the apex will be like a little bit upturned like this. It won't be touching the diaphragm. Okay, so that happens because of right ventricular enlargement. Okay, then the right cardiac silhouette extends a lot beyond the spine. Okay, that happens because of right atrial enlargement. Okay, then you will have cephalization. The pulmonary vessels in the apices will be more prominent. Okay, so these are things that you see in a mitral stenosis chest X-ray. There'll be cardiomegaly. Okay, all that stuff. Okay, so you see cardiomegaly. Upper lobar veins are more prominent. Okay, there'll be straightening of left heart border, upturned apex. Yeah, it's a little bit subtle. Okay, so basically you have to cephalization. You have to see compare up and down. Okay, if you see it's it's more the higher region is more opacified in the apices, then it could be cephalization. But it's also like these things are kind of like subjective, like murmurs, like I heard systolic and I heard diastolic. It could be anything. Nobody knows, but that kind of okay. So cephalization is basically when the pulmonary vessels in the apices are become more prominent than the basal regions. Usually, the pulmonary vessels in the basal regions of the lungs are more more prominent. Okay, but if they're more prominent in the apices, it's called cephalization. Okay, okay. So this is these are the findings that you see in mitral stenosis. Okay, straightening of the left border of the heart, upturned apex, um, right heart border more than 2.5 centimeters from the midline. Okay. Okay, so now we'll go to the next one. What is this? Yes, effusion with side, with side, with side. Don't just say effusion with side. Yeah, more of the right. I'm not sure if it's both or not because this cardiomegaly and you can't really see. I think there's some minimal effusion on the other side. Okay. Yeah, more on the right. Okay. Yeah. Okay, and there's also some cardiomegaly. Yeah, so these are like these X-rays are bad because they're really old, and this is like the film X-ray. Okay, so like in our final year, they get these film X-rays that they have, and they explain 4 5 X-rays every class for the whole year. Okay, and these are the ones that come in the exam. Okay, so these are the exam X-rays. Yeah, so they're actually very bad. Okay, and we just mug it up like, yeah, this is pleural effusion. This is why we don't like in final we don't know why we're seeing whatever we're seeing. We just mug up the findings and we mug up the thing. Yeah. Okay. So now what is this? Yeah, so it is not thymoma. I mean, we cannot know for sure if it's thymoma, but it's a mediastinal mass, more likely to be mediastinal lymphoma. Okay, lymphoma. Okay, so mediastinal widening. Okay, so this is mediastinal widening where see the heart is actually there. Okay, but the thing is that this part of the mediastinum has widened a lot. Okay, so the base is the pedicle is wide. The pedicle, I guess. Yeah, this is the pedicle. So there's widened pedicle and narrow base. Okay. Yeah. Okay. So it's more commonly and there's humps and bumps like because of all the. Okay. So this is mediastinal lymphoma. Okay. Okay. So next X-ray. What is this? No, next X-ray. Yeah, I showed this. That's why. Right middle. Yes, correct. That's what you said last time too. I remember. Yeah. This is a loculated pleural effusion. Loculated pleural effusion, yes. Okay, we did this last one. Okay, pleural effusion, that's loculated, yeah. Okay, yeah. Okay, so well loculated envelope-like lesion. Okay, and it's okay. Basically, the other differential diagnosis is like a pulmonary infarction. So if it was a pulmonary infarction, it would have like air bronchograms inside. Okay, so yeah. Okay, it'll have like air bronchograms inside that. Okay, but if it does, since it does not have air bronchograms, it is of pleural origin. Okay, so it is most likely loculated pleural infarction, uh, pleural effusion. Yeah. Okay. Okay. Now what is this, guy? This is not chest X-ray, I know, but anyways, okay, it was there, so I'm putting it. Okay, what is this? Yes, kidney, but what? Stones. Yes. What is the name? There is a name for this thing. Staghorn calculi. Yes. Staghorn calculi, not hydronephrosis. Yes, Struvite zones. Okay. What are the organisms that in something like that? It is caused because of what kind of stones? Yes, proteus. What kind of stones? Yes, yes. Ammonium, magnesium, ammonium, I guess, or magnesium, magnesium, something like that. Yeah. Okay. Yes. So what do you? Okay. Yeah, that's pretty much it, I guess. Okay. Staghorn calculi. What do you guys see in this chest X-ray? Yes, something in the bowel. Not something in the bowel exactly, but near the bowel. Pancreas. Yes. Soups. What is there in the pancreas? Yes. Pancreatic calcification. Okay. So this is what we're seeing in this X-ray. Pancreatic calcification. Most commonly, most likely due to yeah, chronic pancreatitis. Okay. Yeah. Okay. So now we come to this one. So okay. Hmm. It can also, yeah, but more commonly it's due to chronic pancreatitis. That is because the patient is like rotated like this. He didn't stand properly. That's why the clavicle is up and down. What else? What else? What else? No, so don't look at that. That is supposed to be so many circles. Okay. Okay. That is in the right side. What do you guys see in the left side? Yes, left-sided pneumothorax. Okay, there's actually, yes. That is actually the heart. It's kind of got shifted towards that side because of the tension pneumothorax. Okay. There's also some tracheal shift. I'm not even, I think this is the trachea. I have no clue where the trachea is in this one. Okay. This is pneumothorax because you can see more, there's a translucency and, there's deepening of the cardiophrenic angle. Yeah. Okay. So basically, in pneumothorax, there's increased lucency. See, there is shift of trachea. This is the trachea. Okay, the mediastinum. This thing is coming on this side is because of the shift in the mediastinum. Okay, yeah, big space, and it's hyperlucent, increased space. This deepening of the cardio. What is this thing called? Costophrenic angle. Okay, so it's pneumothorax, tension pneumothorax. And it could be, but yeah, so we can't say that. So now there's shift of trachea also, right? The more features suggesting that it could be pneumothorax. Okay, tension pneumothorax. Okay, all right. Now we go to the next one. What is this again? We have a lot of X3s that are like the same. Okay, yeah, lymphoma. Okay, so I literally deleted. There were some 4 5 lymphomas. Half of them. Okay, okay. Again, this is lymphoma. What is this? Bat. Not concerned. Yes, that's miliary TP. It's miliary TP. Okay. I know, right? I know, right? Dude, these are the best. Like, I have taken out the very bad ones, which, I was just like, there is no point of putting this extra one. So, these are very old, yeah. Okay. Next, okay, now, next ones, okay? Okay. Okay, now this one. How do you don't know what college? Okay. Okay. It is not hypertension, but it is close to it. Yeah, I guess there is cardiomegaly too. Kind of, yeah. What else? What else? What else? Okay, so there is mediastinal widening over here. Okay, more than 8 centimeters at the level of the aortic knuckle. You can see this. Okay, yes. Okay, There's increase in size of the knuckle. Okay, and something else is there. Can you see this crescent kind of thing? This thing. Can you see that? Are you guys able to see it? Yes, no? Yeah. So this is an aortic. Yeah. Okay. So this calcification, the aortic calcification, has kind of shifted. Okay, inside. If it shifts inside by more than 6 millimeters, it's called, like it's pathological. So this can be aortic aneurysm. It's aortic aneurysm. You see, aortic aneurysm is basically, dilatation of the walls of the aorta, right? So if there's widening of the mediastinum of more than 8 centimeters at the level of the aortic knuckle, and there's like some shift in the like aortic, this calcification is normal. Okay, it occurs because of old age and everything. But if there's a shift in the walls of the aorta, if there's a shift in that calcification by inwards by more than 6 millimeters, those two things are the ones that we use. Now, like this X-ray is labeled as aortic aneurysm. Okay, and even I was like, what is the difference? Like, why is it not aortic dissection then? But I think aortic dissection is more diagnosed by CT and all. It's not diagnosed by chest X-ray, I guess. Like you cannot really say. Yeah. Okay. So that's why this is aortic aneurysm. Okay. Aortic aneurysm of the arch of the aorta. Okay. Okay. Now this one. Where is soup? What is this X-ray? Yeah. Yes, Yamadud is right. Soup, you have to answer it. Go on. Oh my god, I'm gonna kill you. Okay. 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 Let's stop laughing. Okay. This is chest X-ray PA view. Okay, where there is there's a broad base and a narrow pedicle. Okay. So this is called pericardial effusion. It's called leather bottle sign or lady's handbag sign. Okay. So this is pericardial effusion. You're not getting any cookies from me. Go away. Okay. So yeah. Okay. So this is pericardial effusion. Okay. Okay. Stop laughing, please. Yeah. Okay. Okay. So this is narrow pedicle and wide base. So this is pericardial effusion. Okay. Now you can say like like what is the difference between pericardial effusion and cardiomegaly? Okay. Yeah, I'm sorry. Okay. So the thing is, pericardial effusion is there is enlargement of both the sides of the heart, even the right side of the heart, left side of the heart, like it's enlarged. Okay. Okay. So yeah. Okay. And so this is in the chest X-ray PA view. Okay. In lateral view, there is another finding that's seen in the pericardial effusion, which I posted in One Sign a Day some days back. Okay. Yeah. So basically, how that's an effusion is basically there will be the findings that is there about pericardial effusion is there is narrow base and widened narrow pedicle and widened base. Okay, the base is widened bilaterally on both sides. Okay, yeah, Oreo cookie sign. Okay, so on the lateral chest X-ray, in pericardial effusion, you see an Oreo cookie sign. Okay, yeah. Okay, so why do you see why you see the Oreo cookie sign? You see a radio opaque kind of a thing. Okay, that is the fluid that is in the pericardium between two relatively radiolucent things. Okay, so this radiolucent thing is the pericardial epicardial fat, and this is the pericardial fat layer, something like that. Okay, so I don't know if you guys are able to appreciate in this one. Are you guys able to appreciate? Yeah. This is the lateral view, lateral chest X-ray view, lateral view. SOAPs. Do you understand? No. This is the lateral view. Like we're looking at the chest X-ray from the lateral side. Yeah. You won't be able to appreciate ribs so much. Okay. Okay. Wait. I'll orient you. Okay. This is the sternum. Okay. And this is also kind of cut. It's not the full zoomed in. Okay. Usually, I'll show you another line. Mm. Soups. See over here. Okay. This is the sternum. See, in lateral view, you cannot actually appreciate ribs so much. Over here, you can appreciate. This is the spine. And this over here, this opacity is the heart. Yeah? Yeah. Okay, so that photo which I'm showing you is just a zoomed in portion of this one. Okay, it's not the whole X-ray. Yeah. Okay. So now we'll go to that one. I don't have water with me over here. It's okay. Okay. So so this is pericardial effusion. Okay, so Oreo cookie sign. Okay. Paracardial fat and between the paracardial fat and epicardial fat. Okay. Okay. Yes. Okay, what is this, guys? Let's do quickly. Yeah, abscess, air fluid level. Okay. Okay. And this is also, yeah. And the second thing is, this is also, as I said earlier, there's also microcardia. So basically, microcardia basically means that when the cardiothoracic ratio, the width of the heart and the width of the thorax, 42%. If it's less than 42%, it's called microcardia. Okay. 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 40, less than 42%. Yeah, that is the abscess. Yeah, that's the abscess.
No.
Air fluid level. Yeah, with air fluid level. Okay. So see, abscess basically means there is a cavity lesion, and inside the cavity there'll be an air fluid level. There'll be some pus. Okay, so that is basically an abscess. Okay, it's just gonna get over a little bit. I think it'll be over by like 3:15. Okay. Okay. So there can be many causes of microcardia. It could be due to adrenal insufficiency, old age, cachexia. Okay. Okay. So this is not the X-ray from my final exam thing. This is from net. I took just to make you guys appreciate microcardia more. This is a patient of anorexia nervosa. Okay. So you can see the small heart over here, right? Yeah. Okay. Now we go to the next one. What do you guys see here? This is also kind of a bad X-ray, but okay. What do you guys see over here? Uh, this is not tough, but when tough comes, you have to say tough. When tough comes, guys want to say tough. No, it's not tough. Yeah, it's not a child. Correct. Teratology of Fallot. It's a like a congenital heart. Mm, yeah, disorders. Okay, so this one, there's cardiomegaly, kind of. Okay, kind of cephalization. There's some homogeneous opacification bilaterally, right? Okay, so this is cardiogenic pulmonary edema. No, this is not hilar mass. Cardiogenic pulmonary edema. It's not like a good X-ray, basically. Yeah, you can also say there is some bad sign kind of thing going on here. Yeah. Okay, so there's multiple bilateral heterogeneous opacities. Bronchivascular markings are more prominent over here, right? And cardiogenic pulmonary edema. Yeah, so basically, we just do the memory kind of learning. Like this X-ray is cardiogenic. I just know it. Okay, like and I'll just learn whatever the finding is. Okay, this is just gastric. This is below the diaphragm, so it's just gastric shadow. Gastric shadow. What is this? Bats. Oh no. Wait, yeah, it's that one. Now I don't remember what is this. Yeah, it is that only. Yes, it's miliary TB. Okay, this is a relatively good-looking X-ray. Yeah. Okay. Okay. Now next, this one. That is just the normal hilar thing. Nothing really is happening over there. It's pretty normal. Okay, like you can say it's not very well exposed. That's why it's becoming like that. Yeah. So miliary means millet-like. Basically, this is the tiny nodular opacities are seen everywhere. So the person who discovered this X-ray, that time he probably used to grow millets or something, or he just at that time thought that this looks like millets. Okay, so he named it miliary TV. Yeah. Okay. This is abscess. I'm just gonna move past. Okay. This is. I thought I deleted all these things. Why are they still there? This is again mediastinal lymphoma. Yeah. Okay. Um, what is this, guys? This is. Yeah. This is actually like bilaterally dilated hilar vessels. This is pulmonary hypertension. Okay. Another thing in yeah. See, if you see it in both sides, over here there's an opacification also. It's not just at the knuckle. See, the knuckle will be somewhere over here. Okay, and another finding in pulmonary hypertension is that हम आके खा लेंगे बाद में. Okay, the another finding in pulmonary hypertension is that like the pulmonary the vascular markings on the rest of the lung field will be less. Okay, that will be less because of the dilatation of the pulmonary vessels. Okay. Okay, so that's called pruning effect. Okay, we're here pruning effect. Okay, so this is pulmonary artery hypertension.
Can I speak?
Yeah, sure.
What does high pulmonary pressure mean?
Okay,
Uh,
so
how is it related to being what? How is it percent?
it's not. Yeah, so basically pulmonary artery hypertension means there's increased um, blood pressure in the pulmonary vessels. Okay, so chronically this increased pulmonary blood pressure in the pulmonary vessels causes pulmonary artery dilatation. So that is what is visible in the chest X-ray. So this hilar regions over here, okay, this is where the left and right pulmonary arteries are supposed to be situated. Okay, so if there is dilatation and there is increased blood flow because of increased pressure, okay, there will be opacification, increased opacification of the hilar region. Okay, that is what we see as that is why we call it pulmonary. Like this is like we're not sure, but we think it is due to pulmonary artery hypertension. And another thing is because of that there'll be decreased pulmonary vascular markings in the rest of the lung. Okay, like okay, so that is called pruning effect. Is it okay? Pruning, PRU. Okay. Um, yeah, what is this now? We did this before. Not diffusion. MS. This is MS. Okay. Straightening of the left quarter of the heart, cephalization. Okay. Yeah. Okay. Okay. What is this? I haven't taught this before, but I think you guys can figure it out. Yes, it is diffusion. Correct. Okay. So basically, there's an air fluid level over here. Fluid is kind of more translucent, so airy. This is called hydropneumothorax. Okay. Hydropneumothorax. Yeah. Okay. So see, basically, it's like pleural effusion, but in pleural effusion, you won't have like this. Okay, you'd have like, and there's more increased translucency over here. This is hydropneumothorax. Well, this X-ray is marked as hydropneumothorax, so that's why I'm calling it. Yeah, I think so. Also because of if there is an air fluid level, it's how why it comes like this. What are these purple things? um, See, the only reason I can say pneumothorax is, see, how do we say pneumothorax? We say pneumothorax if there's increased translucency and if there's absence of the normal reticular markings region. So in this region, compared to this region, you can see it's more translucent, this area compared to this one, okay? And you can see that the reticular markings are relatively more absent compared to this, okay? So, so it is hydropneumothorax. And this straightening is based because of the fluid. See, the thing is, that these are college X-rays, so I am just like there's no explanation given. I'm trying to think of an explanation and say it, right? Yeah. Okay. Yeah. Okay. Okay. Now, what do you guys see over here? Yes, there's microcardia. Yes. Yes. What else? There's a cavity. Okay, so there are a lot of reasons why a patient can have a cavity. Okay, it could be due to abscess, it could be due to malignancy, it could be due to septic pulmonary emboli. It can also be due to TB, right? So in this case, it's more likely like we don't know what it is. It is a cavity lesion. That's all we can say. But given the microcardia, it can be due to in an old person or a cachectic person. So it could be due to TB, right? That oral hygiene. Yeah, it could also be abscess. Yeah. Okay. Hmm. So that is because I think that is also because I really don't know why. It's just yeah, because of the position of his hands. I that clavicle is like that. Yeah, probably Edge is right. I think that's why. Okay, now this one. This one is also mitral stenosis. Okay, I'll just move on to the next one. Yeah. Okay. Mm, what is this? Mitral stenosis is stenosis of the mitral valve. So I mean, I don't know what you're asking. See the straightening of the left border of the heart and stuff. If it becomes like, yeah, so it becomes now, it gets narrowed down due to, yeah, so yeah. So that why there's straightening of the left border of the heart. Okay, what is this? Soups. Yes. What effusion? There's so many kinds of effusion. Pericardial fusion. Okay. So this is pericardial effusion again. Okay. There's the widened, you know, base. Okay. Yeah. Okay. Okay. And what is this? Mediastinal lymphoma. Okay. I just wanted to like differentiate. Okay. That's why I put this one on here. Okay. Yeah. Fine. Yeah. Yeah. Now, what is this? Bhalu. And yes, tough. Okay. So this is tough. Child X-ray, boot shaped heart, right? Yeah. Okay. Okay. So yeah, the upturned apex and concave pulmonary segment. Okay. What are the things that we see in top? What are the four teratology? What is the part of the teratology? Yes. P for pulmonic stenosis, R for right ventricular hypertrophy, O for overriding aorta, and V for ventricular septal defects. Okay. So those four things. Yeah. Tobio wrote them all out. Okay. So those are the four things. Now what is this? Soup. What is this, guys? Give explanation. Okay, so basically, because of VSD and everything, because of pulmonic stenosis, usually. Oh, wait a second. Usually, yeah, down one. You mean this one? Yeah. Okay, so this is not pericardial effusion. This is pericardial effusion, but this is also pneumopericardium, pneumohydropericardium. I think that's what it's called. Hydropneumopericardium. There's also air in the pericardial cavity and fluid in the there's air fluid level. Yeah. Okay, so what are the like does it it's not very common, and when it happens it's because of a gas producing organism infecting the pericardium, or because of a fistula connecting the pericardium and the esophagus. Okay, so that usually occurs and the pericardium gets infected. Okay, I'll explain this. Basically, see, this is the pericardium lining, and there's air fluid level within the pericardium, right? So this is hydropneumopericardium, right? Okay, so yeah. Okay, so hydropneumopericardium. Okay, this is not a very common thing, I guess. It's there in our X-ray collection. There, yeah. I think it's about to get over. This is also mitral stenosis only. I'm just gonna skip it now. See here, you can see the upturn, and those are the breasts. I think we've seen this X-ray before. Yes, what is this? This is something new. Yeah, so no, I'm saying one of the causes of hydropneumopericardium is, it can be due to any gas producing bacteria that is infecting the pericardium, or, if there's any fistula with the esophagus, between the pericardium and the esophagus, so that can cause uh, hydropneumopericardium. Okay, what is this? What do you guys see over here in this X-ray? हाँ, हम आएंगे थोड़ी देर में, क्लास चल रहा है. It's okay, it's okay. Let's finish this. It's okay, it's okay, it's okay, it's okay. Arey, answer this, guys. Okay, so in this one there is, do you guys see any air fluid levels, cavity? So these two are cavity with air fluid levels. Okay, this is a chest X-ray of bronchiectasis. So when we suspect bronchiectasis in a patient, the initial investigation that we do is chest X-ray. It helps us to see the features of suggestive chest X-ray. Eventually, we do chest CT. If the chest X-ray is negative, it does not rule out bronchiectasis. You still have to do chest CT. Okay, so the features that you see these cavity lesions with air fluid levels. You see tramp track appearance because of bronchial wall thickening and inflammation. It causes tramp track appearance. So you see all these things, right? These things. You can see one over here. Just zoom in a bit more. Yeah. Okay. Yeah. Okay. So this is bronchiectasis. Okay. There'll be parallel tram track appearance, and there will be thin walled cyst with possibly air fluid levels. Yes. Usually, initially you do chest X-ray, but eventually you do CT is the main thing. Yeah. In late stages, you see honeycomb. So this is honeycombing. Okay. Which is more visible in a chest CT than an X-ray. Right. Yeah. Okay. Honeycombing is basically honeycombing like structure. This is honeycombing. Yeah, bronchiectasis only. Late stages of bronchiectasis, fibros. Yeah. Okay, I'll go to the next one now. I think this the last one. Yeah, last. Okay, what is this? I think I already showed. Yeah, collapse with pneumothorax, not hydropneumothorax. Yeah, last one is hydropneumothorax. Yeah, this is collapse with pneumothorax of the right side. Okay. Yeah. Okay, and the last one is hydropneumothorax of the left side. Yep, that's it. We're done. Okay. Thank you guys for answering everything. I'll send in the notes after some time. In pneumothorax, there'll be increased translucency. Okay. So there's increased translucency, absence of reticular markings. That is pneumothorax. Okay. Mediastinum does not necessarily have to shift. Mediastinum shifts only in tension pneumothorax. Okay. And because of pneumothorax, there is like a what do you say? There'll be like the lung will be pushed, like the alveoli will be collapsive atelectasis, I think. Okay, so there'll be collapse of the lung because of that. Okay, so that's how it happens. Okay, okay, guys, I'm done.